Good morning, good afternoon, everyone. Welcome to this DCB Academy lesson on important trials presented at TCT 2024, which will be presented by Dr. Lazar from Romania. Please, Dr. Lazar.
Hi, everybody. Sorry for the short notice changes. It's my wife's birthday and she received a gift, a trip to Spain. So hello from sunny Spain. Today I'm gonna present to you some of the trials presented in TCT 2024, which I found to be very interesting, especially for my daily practice here in Romania.
Good morning.
Hi, everybody. So, first of all, I'm gonna talk about some of the trials regarding aortic stenosis and when is the best moment to intervene in the pathology, in the replacement of the valve. One of the trials that captured my attention was early TAVR, which was the evaluation of transcatheter aortic valve replacement compared to surveillance for patients with asymptomatic severe aortic stenosis. The paper was published in the New England Journal of Medicine. And what is the background for this trial? As we all know, in 2021, the European guidelines changed, and from then on, replacement of aortic stenosis in asymptomatic patients was guided only in patients with left ventricular ejection fraction below 55, or as a class 2A, or in patients with very severe aortic stenosis with a gradient of more than 60 millimeter mercury or more than 5 meters per second velocity, or with rapid progression, or with markedly elevated BNP levels. In other categories of patients with asymptomatic aortic stenosis, the main recommendation, as we can see in this picture, is just to clinically assess the patients and see them every 6 months or so. However, in many countries, and it is my country as well, the case, in most of the cases, when you have a patient with asymptomatic aortic stenosis, from the moment you put the diagnosis of severe aortic stenosis to the moment when he really gets to have a TAVR or a surgical replacement of the valve, it might take 1 year and more. So this trial investigated whether intervening in the early phases of aortic stenosis, even in the asymptomatic patients, could bring any benefits. It was a multi-center randomized controlled trial, which compared SAPIEN 3 or SAPIEN 3 Ultra from Edwards, which are balloon expandable valves, versus clinical surveillance. The study included patients older than 65 years with asymptomatic severe aortic stenosis and with anatomy suitable for transfemoral TAVR, and excluded patients with STS score more than 10% or with ejection fraction below 50 or any other class 1 indication for aortic valve replacement. The patients were randomized in a 1-to-1 fashion, and the trial set as primary endpoint a composite of death from any cause, stroke, or unplanned hospitalization for cardiovascular causes. The secondary endpoints were a favorable outcome at 2 years, defined as being alive with a Kansas City cardiomyopathy questionnaire over 75 points, and that had not decreased more than 10 points from baseline. Also, a secondary endpoint was a composite of integrated measures for left ventricular and left atrial health at 2 years, which were defined as an absolute global longitudinal strain of left ventricle of more than 50%, a left ventricular mass index below 150 grams per square meter for men or below 95 for women, and the left atrial volume below 34 milliliters. Other secondary endpoints were change in left ventricular ejection fraction from baseline to 2 years, new onset atrial fibrillation, or a composite of that and disabling stroke. The authors estimated that 900 patients with at least 271 events would provide a trial with at least 85% power to show the superiority of early TAVR over clinical surveillance. Therefore, they enrolled 901 patients.
Hey, Leo.
Yes.
Excuse me to interrupt. How many studies do you want to present today? Because
Just
you have
3.
15 minutes for everything.
Just 3 of them. This one is the most important one that captured my attention.
Okay.
And I'm gonna talk more on this one.
Keep an eye on the time. Yeah.
Yeah, sure. So the study included 901 patients, from which 90% were considered asymptomatic after a treadmill stress test, and almost 10% based only on medical history, with a median follow-up of almost 4 years. The patient's characteristics, baseline characteristics, were very similar, with similar aortic valve velocity, peak velocity, mean transaortic gradient, and aortic valve area. The patients were not very sick. Less than 30% were diabetic, and very few of them had previous stroke or myocardial infarction. After almost 4 years of follow-up, we can see that the primary endpoint, the composite of stroke, death, and unplanned hospitalization for cardiovascular causes, was of 26.8 in the TAVR group and 45.3 in the clinical surveillance group, with a significant p-value. This was mainly driven from unplanned hospitalization for cardiovascular causes, which were only 95 in the TAVR group versus 186 in the clinical surveillance group. Moreover, in the secondary endpoints, the patients had a superior KCQ questionnaire in the TAVR group. Therefore, there were more alive patients with a better clinical health in this group, as well as regarding the left ventricular and the left atrial main measurements in this group. No significant differences in death or disabling stroke as a secondary endpoints, as well as the new atrial fibrillation. If we look at the Kaplan-Meier curves, we can see that there is a big difference between the two groups early in the surveillance in the 6 months, and the curves in picture A and D are supposable. So the main difference between the two groups in primary endpoint, which was the composite, is mainly driven from unplanned hospitalization for cardiovascular causes. There weren't any significant differences in stroke, which is pretty strange in this group, is that the stroke occurred more in the clinical surveillance group. But the authors didn't find an explanation for this fact. Also, the curve is very supposable with a conversion to aortic valve replacement, which took place in the clinical surveillance group. We can see that in the first 6 months, 26% of the patients already had to have TAVR, and the median time from randomization to conversion to aortic valve replacement was 11.1 months. After 5 years, almost all patients had the valve replaced. So the percentage of patients with a left ventricular ejection fraction of 60% or lower increased from 12% at screening to 20% at the time of conversion to aortic valve replacement. And also the median BNP levels increased in this group. The mean 6 minutes walk test distance decreased by 46 meters, and the recovery occurred within 30 days after the procedure. So after this study, I would have 2 questions. Is there a rationale to wait another median replacement? from my point of view, when we have a patient diagnosed with severe aortic stenosis here in Romania, we already have to plan him for TAVR, because it sometimes takes 2 months only to have a angiography for him, and another 6 months or 1 year to plan him, to put him on a list for TAVR. That would be my question for you. How is your daily practice when you have an asymptomatic patient with aortic stenosis?
Yeah, first of all, can you come back on the exclusion criteria of the study? First of all, we have to put these into the context of daily life.
These are the exclusion criteria.
Inclusion, okay, symptomatic.
STS.
Exclusion of STS more than 10, less than people of 50.
Basically,
okay,
low.
So all of them were preserved.
All of them were.
Leo, these patients also had almost critical aortic stenosis, isn't it? Like mean velocity was more than 5, gradient was more than 50.
Exactly.
So really quite severe, almost bordering on.
So is there any frailty score assessment or frailty score exclusion criteria? Because, for example, yesterday in my clinic, I visited an 88-year-old female. She was very frail, very, very sick. You could perceive that. She was asymptomatic, and she had an aortic valve replacement with a failure after 20 years of the replaced valve. So I don't know if this patient would have been randomized for this study, or being her so frail, she would have been excluded. Because yesterday, my indication was to observe, because she was asymptomatic. So my indication was to observe her for 6 months and then reassess.
But these were all native valves, right? I don't think they included valve-in-valve.
Okay, so this is an exclusion criteria, but it's not written
I think
here.
so. Yeah, it's not. I think these were all native aortic valve stenosis.
Okay.
Is that right, Leo?
All of them were native, and basically they were low risk, everyone.
Yeah.
Okay, so they excluded frail patients. Okay, so we have to put this into the context. So frail patients are excluded by this study.
Yes, and
I understand
no other
I understand your
comorbidity.
problem with the waiting list and with the possibility of implanting only a few valves in Romania. I think that this study probably fits more into a system with a large experience and availability of TAVR. Okay, because otherwise, you can indicate the TAVR, but if the patient has to stay in a waiting list for a year, really it makes no sense. So your problem, I think, is more, how can I say, local problem.
Yeah.
So it cannot be put into the context of this study, I think.
But we know that the natural progression of severe aortic stenosis, 50% don't make it to 5 years. We know the valve narrows at 0.1 centimeter square per year. So these patients, we know they eventually will end up needing the valve. It's whether when they develop symptoms, I think, is the question, right? They all eventually will develop.
But the problem is that it can be too late when they develop the symptoms. So I think that this is a timely study that responds to a clinical question. However, the problem is that Leo can put this patient into a waiting list, but if they are not if you don't have the valve, what can you do? You can just indicate it, but if you don't have the valve, you cannot implant it.
Yes, but if you wait, then if you have a system that doesn't have so many resources, when you wait for the patient to become symptomatic, if you put then on a list and it takes another 1 year, maybe the patient won't even get to the valve replacement.
No, in fact, for example, we have a waiting list which is of 2 weeks for TAVR. In Italy, it depends on the center, but it's 2 or 3 months. It's not a year. Okay, so that's the problem. So you should go with this study to your politics and say, okay, guys, this is a problem. Are you investing more in the healthcare system or not? That's the question.
Yes.
Hello, guys. Sorry. Can I say, Leontine, something?
Please.
Okay, thank you for your presentation. Personally, thank you for your presentation again. Fortunately, unfortunately, based on my reading of the trial, there is an important issue to be considered, that the primary endpoint investigating and considered all hospitalization for cardiovascular cases as referring to the primary endpoint. And this is why I believe that the results were more favorable for the TAVR group, if especially based on the nature and on the design of the trial. Because if you design a trial with an open label design, and you say to the patient, okay, you're asymptomatic, you have a severe aortic stenosis, and I can randomize you to an approach to change your valve, or just to clinical management, I think that the patient may be concerned and can look at the internet and look what is the most frequent cause of aortic stenosis, and this was happened. This is what happened. This has also happened to me with a vulnerable trial. When I say to the patient, I would like to randomize you and your plaque to medical treatment or stent treatment, because when patients are randomized to medical treatment with a plaque, they say, oh, well, I have an almost severe plaque and it doesn't be stented. This is the first concern. And the second one is related to the durability. With this trial, if we consider this trial positive and we receive what they say, we may start implanting TAVR in patients that are 60 or 62 years old, but we don't know really about the long-term durability and also an evolving valve procedure. So those are my main concerns.
Okay, Giovanni, your first point is a methodological point, which is, I think, an important one. I agree with you methodologically, but everybody would like to see a study with the primary endpoint of death, or cardiac death, and see if TAVR is better in these patients. The problem is that you should enroll 4,000 patients, so nobody is gonna ever do this trial. So we have to be also pragmatic with this type of trials. There is a clinical need, and then we have to adjust the primary endpoint to that. So nothing is perfect, but also the New England Journal of Medicine accepted this trial. So I think that they couldn't do it better. I mean, okay, so you are right. The question is still there. There is a bias. There is a bias of selection, and there is also a bias from the patient being this an open label design. But in the end, I think it will be difficult to do something better. And on the indication for a younger patient, usually there is a gatekeeper, which is the cardiac surgeon. So I think that the cardiac surgeon for a patient without comorbidity, 60, 62-year-old, would not allow you to do a TAVR, or, you can do that, but you can have local problems with your cardiac surgeon. Anyhow, a valve that, an aortic stenosis in a young patient should be treated somehow. So from the data that we have so far with the Medtronic and with the Edwards, we know that the durability is not a big issue, because at 10 years, we have a good durability. So far, this is not a problem in real life.
Thank you.
Okay, so Leo, do you have another study?
Yes, I also had another study on aortic valve stenosis, but I think we can skip it because
You can go to the results of this study, just if you have a flow chart.
Yeah, the EVOLVE trial early valve replacement, also guided by biomarkers of left ventricular decompensation in asymptomatic patient with severe aortic stenosis. Also randomized trial in UK and Australia. And I'm just gonna go to the flowchart. There were 224 eligible participants, from which 29% had a bicuspid valve, aged in a median 73 years old. There were 111 conservative patients and 113 in which
and the primary endpoint is
the primary endpoint was just a sec. Also composite of all-cause mortality or unplanned aortic stenosis, related hospitalization. Yes.
Okay. So let's go to the primary endpoint. Yeah.
Okay. So the primary endpoint was not reached, as 20 events were in the early intervention group and 25 in the conservative management.
Yeah, with a 200 patient study, how can you reach a primary endpoint of this study? No. So it would be interesting to understand which were their calculation for the population. So did you go through that? Which were their assumption?
Yes, the assumption was that they should have initially they assumed that they should have almost 400 patients, but then after recalculation using cardiac resonance, magnetic resonance, they calculated that even less patients and events would be enough. However, they changed that during enrollment. So the study was a little bit biased from the initial phases.
It's not biased, you know. How can you include the cardiac resonance to determine the population if the primary endpoint is clinical? Well, I think this is. Do you have the paper? Can you put in the chat the paper of this trial, the publication, if they did simultaneous? Because I would like to go a little bit deeper into that.
Just 1 second.
No, also later if you want, you know. But,
okay.
There is a big methodological issue for this study. You know? If you randomize, if you do a study with 2 patients, you randomize one in one group and the other in the other, it's difficult to find to obtain the primary endpoint that is expected. No, so this is the same concept.
Yeah,
but I don't know this study, so I want to be a little bit more go into details.
Yes.
Yeah. Thank you. Okay, and then you have a third one.
So they failed to reach the primary endpoint.
Yeah.
And the third one is the DCB beef trial. We talked about it on the group a few months. I mean, when it was discussed in the TCT. I don't know if you already read it.
Not the entire paper, not personally. I don't know if the other guys did.
It's based on bifurcation lesions, true but simple bifurcation lesions, in which you should or should not use DCB for side branch angioplasty. It was randomized. It was mainly conducted in China with a few centers from Italy, Indonesia, and Republic of Korea. It included only true simple coronary bifurcation lesions with the Medina 111011 or 101 lesions. The inclusion criteria were age over 18 years old, stable or unstable angina or myocardial infarction older than 1 week. Reference vessel diameter more than 2.5 millimeters, baseline diameter stenosis of more than 50% with a side branch.
We can skip this, the rest of this.
Okay. The procedural aspects is basically the recommendation of VBC Bifurcation Club, so I'm gonna skip it.
No, this is important. No, this is important.
Okay, so
what did they do?
They pre-dilated the main vessel without pre-dilating the side branch. Then they stented. If the side branch stenosis were significant, meaning more than 70%, then they randomized the patients to either NC ballooning the side branch ostium, or pre-dilating it and putting a DCB there, and the final pot.
Okay.
For the DCB treatment, they recommended at least 60% 60 seconds inflation, either in one session or two short sessions of 30 seconds. It's the first time I hear about it. And they use the kissing balloon inflation with using two non-compliant balloons and repotted with another large non-compliant.
So they used. So let me understand. So non-compliant, then DCB, and then again they did a kissing balloon in the DCB arm also. It's not clear here.
Yes, yes, and using the cutting or scoring was not allowed after stenting the main vessel for the side branch.
So they use DCB, and after DCB they use kissing and repot.
Exactly.
Okay. To the side branch, and then all of them have NC balloon kissed with pot after.
Yes. For me, another strange thing was this one. It's also worth mentioning. They took troponins every 6 to 9 hours within the first 24 hours, and every 24 hours thereafter until 48 hours post PCI. This will explain some of the strange results.
Yeah, I agree.
The primary endpoint was defined as the occurrence of MACE within 12 months, which included cardiac death, target vessel MI, or clinically driven target lesion revascularization. And secondary endpoints were all-cause death or cardiac death, MACE without periprocedural MI, periprocedural and spontaneous MI, target vessel MI, clinically driven TLR or TFR, and geographic and clinical procedural success and crossover from 1 to 2 stents. Most of the patients, the patients were very similar in both groups. Most of the patients were presenting with unstable angina in the first place, and also they weren't very sick. Most of the patients had a 2-vessel disease and a low syntax score. Also, most of the procedures were on the left anterior descending artery with a diagonal as a side branch. This was the flow chart with all the patients.
Yeah, it's a big study. So 1,200 patients.
Yeah.
Okay, and 858 after exclusion, 784. So this was a sponsorized or an investigator-driven study?
I think it was investigator-driven study. I didn't find any information of, as it was.
Okay, and what type of DCB did they use?
Paclitaxel DCB.
Only any type of paclitaxel.
The brand, if they put a brand, only a brand. It was mentioned that is paclitaxel DCB.
Any paclitaxel. Okay.
Yes.
That's fine. Not only one. Okay, got it.
No. Any
paclitaxel. Next.
Yeah. So, most of the procedures were transradial.
Yeah, okay. This part I think is not interesting.
It's not very important.
Yeah, unless you have some specific items that you want to underline.
No.
Technically, I don't know. Okay. Okay.
I think the only thing that I noticed was that more than 70% was prepared with semi-compliant balloon.
Yes.
So they didn't use much NC balloon or cutting or scoring. So more than 70%, and majority of the lesions were, I think, less than 15 millimeters, even in the LAD, even in the main vessel.
And short lesions mainly, and without calcification. This was a criteria from the beginning. Small amount of calcific lesions. Imaging was not.
And short lesion in the side branch. Yeah.
Short lesion in the side branch, and 40 millimeters in median in the main branch.
Okay. Okay.
Okay, so the primary endpoint was achieved with MACE occurring in 28 patients in the DCB group and 49 in the non-compliant balloon group. Most of the secondary endpoints were also reached with MACE without periprocedural MI occurring in 10 cases in the DCB group and 20 in the non-compliant balloon group, and target vessel MI 22 versus 43 in the
Yeah,
NC.
so it seems that the primary endpoint is driven mainly by the periprocedural MI. No?
Exactly.
Exactly. Yeah, but as you were pointing out before, but how is your explanation of this increase in periprocedural MI?
There
in
were.
the
I'm
non-compliant
gonna show you this graphic. In this graph, we can see a lot of periprocedural MIs. Comparing to other studies using DCBs or even angioplasties, there are 10.9% cumulative target vessel MI in the NC.
Yeah, but why?
I think there were many microvascular embolizations, and taking troponins every 6 hours, they defined it as MI. Not every patient.
No. But my question is, why DCB had lower periprocedural MI? I don't understand.
They don't have any explanation. They talk about it, but they say they don't have any explanation for it. I'm not sure why they had such a big difference in periprocedural MI in the DCB and the NC.
And when was this published?
I think
TCT.
in
No, the publication.
in JAC.
Yeah, when?
October.
Because they didn't. I was not reviewer of this trial, so I would have been much more. How can I say? Had more criticism on this, because the primary endpoint in this study is completely driven by periprocedural MI that you cannot explain. So
Exactly.
if you just look at the the graphical abstract or read the conclusion of the abstract, like many people do when they deal with science, you say, okay, so now finally we have a strong recommendation for using DCB for the side branch in bifurcation. First of all, here you're excluding complex bifurcation. Secondly, this is just a specific technique of using DCB after main vessel stenting, which is different from what I do, from what Bruno Scheller does, from what Fernando Alfonso does, we are the three most experienced in the world for DCB. And third, most important thing, the primary endpoint is completely biased by this quite, I would say, weird assessment of periprocedural MI with serial. So you are very smart in underlying this, Leo, serial analysis of troponin, which you never do in your clinical practice. You never do that. In many centers, you don't do any troponin after PCI. We don't do it anymore unless there is a reason. So
And
this study is...
were asymptomatic. The patients were asymptomatic and were the troponin was every 6 hours taken from them.
Yeah, there was really no indication for me to do that. So